Hello everyone, my name is Delora, and today we're going to be talking about migraine treatment. If you've already watched my headache diagnosis lecture, you might be wondering, what about treatment for all of the other conditions? And while that is important, it's not really tested on your NBME or on step 1. And since migraine is the most common of the headache disorders, we're only going to be focusing on migraine treatment today. So, before we get started with the medications, there is something very important that we all need to understand, and that is most migraine patients are probably going to need 2 categories of medication. One is prevention or prophylaxis, you can call it either, and the other is acute or abortive medication. So just to kind of draw a parallel here, if you have someone that's had a heart attack or some kind of cardiovascular event in the past, you're probably going to have them on aspirin or something to try and prevent them from having another heart attack. But you are also going to give them nitroglycerin, and you are going to tell them, if you start to experience chest pain, you need to take this nitroglycerin. Both things have a place, and it is the same with migraine therapy. So we want to try and prevent patients from having migraine attacks, and we also want to be able to treat the migraine attacks when they have them, because the reality is prevention is probably not going to prevent all of the attacks. So both things are important. We're going to talk about prevention first, and then we're going to talk about acute and abortive medications. So prevention and prophylaxis. So you can lump this stuff in with blood pressure medication patients would take on a daily basis, diabetic medications patients would take on a daily basis, that kind of thing. So this is stuff that patients would be doing every day or on some kind of scheduled regimen to try and prevent them from having migraine attacks. So we have some traditional drugs, Botox, CGRP blockers, and then some devices. So let's go through each. So this is a table that is showing you different drugs that can be used to treat migraine along with their levels of evidence. So it's really important for us to be familiar with the level of evidence that is available for drugs that we use to treat anything, which is why I have included this here, because you will see migraine treated with a bunch of drugs on this list, and not all of them have good evidence. Some of them don't have any evidence at all. For example, Sketchy tells you that verapamil can be used for migraine prevention, and it can, but it's level U, which means there's inadequate evidence. So just be careful. Just because someone tells you that something can be used to treat migraine doesn't mean that there's actually good evidence for it. A lot of it is anecdotal. Okay, so let me explain why I have called these traditional drugs. Basically, there were almost no options for treating migraine up until 2017, when we got a bunch of new drugs that hit the market. So before that, there was a lot less options to treat your patients with, and these were kind of the mainstay of prevention in migraine. So I listed here the ones that are level A and level B evidence, and I kind of want to talk through them mainly because A, they are going to show up on your NBME and they're going to show up on STEP. And also, if you're treating someone's migraine in real life, you're probably going to have to put them on one of these medications first before their insurance is going to pay for one of the newer ones, because they're new, so they're expensive, and insurance companies don't want to pay for an expensive medication before you've tried the cheap one. The other unfortunate part about these medications is we don't really understand why it is that they help people with migraine. They honestly don't do a super great job of helping people with migraine. They were kind of found by accident. So topiramate, or Topamax, it's a seizure drug, and it was just kind of discovered by accident that when people were put on topiramate, or Topamax, their migraine got better, and so it became a treatment for migraine. Propranolol, metoprolol, these are beta blockers. The main thing that I find interesting about this is the original study on propranolol as a migraine preventive actually took 30 patients that were already on propranolol, which had already helped their migraine, and compared them with other patients that had migraine that were not on propranolol. And of course, it found that the ones on propranolol were doing better than the ones that were not. But if you know anything about study design, this wasn't a good study design. It was a very biased study because the treatment group had already found benefit before the study ever started. So you'll see this come up a lot on tests. They love to tell you that there is a patient that has high blood pressure and migraine, and they want you to give them a beta blocker to fix both problems. On the test, it's the right answer. In the real world, it doesn't always work like the test would want you to think it works. Depakote, valproic acid, both also seizure drugs. The main problem with these two is that they have a laundry list of side effects, and they can cause weight gain, which is not normally something that young women particularly want. Topiramate is better in that aspect. It doesn't cause any weight gain. Neither does propranolol or metoprolol, but you have to be careful with those in people that have low blood pressures or low heart rates, because you don't want to drop their blood pressure or their heart rate down too low. And then level B, we have amitriptyline and venlafaxine. I haven't seen these on tests as much, probably amitriptyline more than venlafaxine. Another thing that I would caution you about more so in the real world is sometimes people think this person is depressed and they have migraine, so I'm going to put them on venlafaxine and it's going to fix both things. And it doesn't necessarily do that. So my recommendation to you is to, at least in the real world, think of migraine as a separate issue from other things, and don't try to do the let's kill two birds with one stone. So just to reiterate quickly, for testing purposes, you will probably see topiramate, propranolol, amitriptyline, and you may even see verapamil, even though there's not good evidence for it. And it will probably come up on a test question asking you what drug would you use for prevention for someone's migraine. So Botox. Botox you may have heard of primarily for cosmetic uses. And you've probably learned about onabotulism toxin at some point during medical school. So how it basically works is it targets the clathrin-coated pits so that they aren't able to dock on the neuromuscular junction and release acetylcholine, which would result in pain transmission. So we need to have a brief discussion about the two types of pain fibers in your body. So one is the C pain fiber and one is the A delta pain fiber. So let's imagine you stub your toe. You stub your toe. Ouch, that really hurt. You get an initial very sharp pain, and then after that you're going to kind of get this slow throbbing pain that bothers you for a few minutes. So the C pain fiber is like that very slow throbbing pain. The A delta pain fiber, which we're going to talk about next, is more of that ouch, initial very fast pain. So Botox works on your C pain fibers, and they figured out that Botox was effective for migraine by actually looking at women that were going in to get Botox injection for cosmetic reasons, and they all kind of noticed, hey, my migraine got better. I'm not having as many migraine attacks, and they're not as severe. And so they started studying it, and they found, yes, indeed, Botox is efficacious for migraine. But what it boils down to is it's a poison, and it is blocking transmission in your nerves, and also in some of your muscles in your face and head. So you can see all of the injection sites here to the right. There's 31 injections that you get every 10 to 12 weeks. And they're just little baby sticks, and you just put a baby little bit of Botox kind of all around. And the goal is that it will keep that C pain fiber, well, the multiple C pain fibers from transmitting pain. Okay, so A delta fibers. So now we're talking about CGRP. So CGRP stands for calcitonin gene-related peptide, and it has been heavily implicated in migraine. So they were studying this, and what they found is that if you take a migraine patient and you infuse them with CGRP, they're going to have a migraine attack. And then if you turn off the CGRP, the migraine attack goes away. So someone thought, I wonder what would happen if we blocked CGRP in migraine patients. And it turns out to be highly effective. So earlier in this talk, I was mentioning that a lot of the new migraine drugs have come out in the last few years. So 2017 is when we started making major breakthroughs. So most of these drugs are very new and thus very expensive, so which is definitely something to keep in mind, especially with insurance. But the drugs themselves are really cool, very efficacious, especially compared to the traditional drug list that I showed you. And we have receptor blockers and ligand blockers. And as well as blocking CGRP, the secondary action of these things is to block that A delta, that fast pain, that sharp stabbing pain that people can feel with migraine. So receptor blockers, we have Aimovig, Qulipta, Nurtec, and then ligand blockers, we have Ajovy, Emgality, and Vyepti. So some of these are auto-injectors. So Aimovig, Ajovy, and Emgality are all auto-injectors that patients give themselves around once a month. Vyepti is actually an infusion that patients go like into the hospital or into the infusion center to get. It takes a few hours. And then Qulipta and Nurtec are both oral medications. So Qulipta, you will take it every day, and Nurtec you actually take every other day for prevention. And Nurtec can also be used as an acute therapy, so we'll discuss it later once again. So this is just to show you what some of these things look like. So you can see in the top left and then also in the bottom right, this is our auto-injectors. Then the top middle, you see Vyepti, which it's just a vial, but it would be an infusion. And then Qulipta and Nurtec are just oral pills that you would take every night. So most of this comes down to preference. Does your patient want to give themselves a shot? Would they prefer to go to the hospital and get an infusion? Or are they going to prefer to take a pill once a day? Okay, neuromodulation devices. Speak of expensive. So these devices are really great, especially if you have a patient who's a little bit more hesitant to maybe get on a medication or wants to try a more natural approach, or in people that medications haven't worked well for. But the biggest issue is affordability Insurances pretty much never cover these, and if you want to buy one of them, it could cost you several $100s, or some of them you have to rent instead of buy. So you can see how that could become quite expensive. Nonetheless, pretty important to know about. I would not expect them to come up on any sort of test, but just for your own reference in clinical practice. So gamma core, vagus nerve stimulator. So I think the hope there is to get the parasympathetic system going to try and shut down some of migraine pathophysiology. Cephaly is going to stimulate the supraorbital nerves. So cephaly is the one that's on the woman's forehead. Nerivio, you put it around your arm, and it sends neuromodulation up to your brain. And then the spring TMS is the one that the person's holding on the back of their head, and it sends magnetic pulses. Most of these are pretty effective, and they work really, really well. The biggest obstacle, again, is just affordability. Okay, so now we're moving on to acute or abortive treatment. So everything we've talked about up until now is something that a patient would take on a scheduled, either daily or monthly basis, or like in the case of Botox, every 10 to 12 weeks on some scheduled time period to try and prevent migraine attacks. And now we are going to talk about medications that your patient would reach for in the middle of a migraine attack, or if they feel like a migraine attack is about to start. So, NSAIDs. The reason why these are here is because NSAIDs treat pain in general. And while a migraine attack has many symptoms besides just head pain can definitely be one of the most bothersome and predominating symptoms, and it can help head pain just like it can help any other type of pain. With that being said, I would not be surprised if someone with migraine does not get benefit from things like ibuprofen or Tylenol. They might, but they also might not. So some other really good options for NSAIDs, there's something called Cambia, which is diclofenac powder that you can mix in a drink and drink it. And that's really cool because it could work faster than a pill that has to sit there and dissolve in your stomach. Lodine or Dodolac, and then indomethacin. What's interesting about indomethacin is that it can actually be used to treat some other types of headache that we didn't even get to talk about. But just NSAIDs in general can be good for headache disorders of many varieties. Just be careful and make sure that your patient is not taking them every single day, because that can lead to medication overuse headache and gastric ulcers and bleeding and decline in kidney function and lots of other things. So just be careful about how frequently they're using these things. Okay, so triptans. Triptans came out in the 1990s whenever it was still predominantly thought that migraine was a vascular disease. I would still say that vascular pathology could play a role in migraine, but it's not predominantly a vascular disease. So the thought was, oh, well, people get a migraine attack and everything gets really swollen and angry and all their blood vessels dilate. So in order to fix the problem, we just need to cause some vasoconstriction, and then the migraine pain will go away. And it sort of worked. And they also sort of cause a lot of really bothersome side effects. So their mechanism of action is that they're a serotonin receptor agonist. So the serotonin is going to help with vasoconstriction. And I would also say, because the triptans have been around since the 1990s, their main advantage is they're not very expensive. So this is a great first line thing for you to give your patients and say, if you get a migraine attack, try this. And the other good thing is, as you can see from this list, there's a bunch of them. So if the first one doesn't work, you can pick another one and try it. And they're all relatively inexpensive. They work decently well, and they all end in triptan. So they're never hard to pick out on a test, because if it's a triptan, it's going to end in triptan, unless they give you the trade name, which I don't think that they would do. So other big things that they love to test on with triptans, they love to tell you that this woman is on a triptan and a bunch of other serotonin-containing medications like SSRIs, for example, and they try to, tell you, oh, what do you need to watch out for? Or either that, or they give you a question where someone is in serotonin syndrome and ask you to think backwards, like what medications might have caused this. And that's where you have to remember that triptans are acting on serotonin and they can cause serotonin syndrome. In real life, I've never seen this happen, but on tests, it seems to happen all the time. So just watch out for that. The other thing about it is that the vasoconstriction can cause other issues with the CV system. When I say issues, they're more like side effects, because nothing really dangerous is happening most of the time. So you'll also get these questions where someone rushes to the ER and feels like they're having a heart attack, but it's like a 35-year-old female. In that case, you could think, I wonder if they have migraine and they took a triptan. It can actually make you feel quite bad. I took sumatriptan when I was in high school, and I honestly thought that I was having a heart attack. So it can feel very real to the patient, and it can be a very unpleasant experience. Although I will say, I tried another triptan, and it didn't cause me to have these same side effects. So I would very much encourage you to try a few of these on your patients before you completely give up. And we do have to be a little bit careful when giving triptans to people that have cardiovascular disease or already high blood pressure. But thankfully, the majority of test questions that they're going to give you is going to be a young, relatively healthy female. And if they're asking what should you do for acute abortive treatment of her migraine attacks, always think triptans first. Okay, so now we are talking about newer migraine medications that have come out 2017 and beyond. So just be aware, these are going to be more expensive. The insurance companies are going to make you fail a triptan first, but they work amazingly. So we have ubrogepant and rimegepant, Ubrelvy and Nurtec, and these are small molecule CGRP blockers. So this all kind of falls into the breakthrough that CGRP is heavily implicated in migraine, and blocking it can do wonders. So we already talked about rimegepant and Nurtec a little bit because it does have a prevention indication, so you can take it every other day for prevention. But you can also take it acutely, abortively, when you feel like a migraine attack is coming on or when you're having a migraine attack. And the really cool thing about Nurtec is it's dissolvable, so it just dissolves in your mouth, which means it's gonna work a lot faster because it will get digested a lot faster because of its dissolvability. So both of these are really great drugs, and it's really great that we have things like this on the market now. Okay, so ditans. Lasmiditan or Rayvow is kind of in a class of its own, and it is a serotonin receptor agonist, kind of similar to the triptans. but different receptor, and it's going more specifically to your trigeminal nerve in your brain, and it probably has some other mechanisms of action that are not entirely well understood. It has a pretty different profile from triptans, even though it has a similar mechanism of action. So big things about this one is it has an 8-hour driving restriction after you take it, and you can have some serotonin effects, so possibility for serotonin syndrome or just other serotonin-like side effects. All right, antiemetics. So it's no secret that migraine very often comes with nausea or vomiting, especially when you're having a bad attack. And as I mentioned in the diagnosis PowerPoint, your gut and your brain are connected through your enteric nervous system. And a lot of times people with migraine actually have gastroparesis, so their stomach just doesn't want to digest stuff because it's angry, because the brain is angry. And so out of that has come this idea of using antiemetics to help treat the migraine attack symptoms. So I definitely wouldn't have put this in my slide set if I didn't see it come up on step 1 questions. I'm not entirely sure why they like to test this. I don't really think of it as super important. It's something that I probably wouldn't recommend unless a patient has come into the ER with a very severe migraine attack and had already failed other acute therapies. But I want to make sure that you don't miss it if it comes up on the test. So a few antiemetics that could be used in this situation: compazine, metoclopramide, or Reglan is the one that I've seen tested the most, and then Phenergan. And the idea behind it is just, if we calm the stomach down, the gut-brain connection could potentially, the stomach could say to the brain, hey, I'm calm, everything is okay, and then hopefully the brain could calm down as well. And as an aside, if the patient is nauseous or vomiting, it could help with those things as well. All right, nerve blocks. So nerve blocks are really, really cool because it's something you can do in clinic, on the spot, and also just in general, very safe, because all you're using is lidocaine and you're just numbing up the nerves so the patient can't feel the pain anymore, and they get the relief almost immediately. Now, they have to be willing to get stuck with a needle, which some patients aren't, but if they are, this can be a really great just acute option for people who have maybe already failed their other acute medications. They could come into the clinic or some other setting and get the nerve blocks. And the hope is by the time the bupivacaine or marcaine wears off, their attack will have resolved. So you can do a couple different ones: occipital, trigeminal, sphenopalatine ganglion, and supraorbital. And on the next slide, I have some images to show you guys what that's like. So I would not anticipate that you would see this on any test anywhere. It's more so just very clinically useful because we all passed an anatomy course. You have to graduate medical school. And if you see a patient with migraine in any setting and you have access to a syringe, a needle, and some kind of lidocaine, you can do these. So the trigeminal ganglion block, you can kind of see, I couldn't find the best picture, but you do a couple injections right into that trigeminal nerve, which is primarily implicated in migraine. Occipital, you're going into the back. This could be particularly helpful in people that are having neck pain, which a lot of patients do with migraine attacks. The supraorbital one, I would say, is kind of a little bit more on the painful side. patients aren't normally super excited about having a needle put in above their eye. So a lot of people might be more hesitant about that one. And then the sphenopalatine ganglion block actually isn't even done with a needle. It's more of like a plastic dropper. And you stick it through someone's nose. You have them lie on their back on an exam table, and you just put a few drops of lidocaine onto that sphenopalatine ganglion. And if it works, the patient should have almost immediate relief of their migraine attack. And if you were able to use bupivacaine, which is a little bit longer lasting, the relief should last for 48 to 72 hours, by which time we hope their attack would be resolved. DHE, or dihydroergotamine. So this is a very old drug that was used primarily for migraine back in like the 1920s, 1930s. Same kind of idea as triptans. So it inhibits serotonin, causes vasoconstriction, can do some of the same cardiovascular symptom mimicking that triptans can. And it can do some real stuff too. So if you give someone an injection of DHE too fast, it can spike their blood pressure. And you have to be careful not to mix DHE with triptans because they're both causing vasoconstriction, and too much vasoconstriction can be a bad thing. So DHE itself is pretty old, but Trudhesa and Migranol are newer nasal spray formulations of DHE that you can kind of just squirt into your nostril with the idea of aborting an acute attack. You just have to be a little bit more careful with these because they can cause uncomfortable side effects similar to the triptans. I've also never really seen this tested very much, but it might come up. So devices can actually be used for both prevention and for acute attacks. So the two that are mainly used for acute attacks are Nerivio and GammaCore. So that would be one advantage to having a device, especially one of these two, is you could regularly use the device for prevention, and if ever you have an acute attack, you could just use it an extra time to hopefully abort your attack. Again, the main thing is just how expensive they are. Okay, so lifestyle modifications. Just kind of up front, I think that a lot of people with migraine have these things suggested to them even before they get treatment suggested to them. So while lifestyle modifications are very important with people that have migraine disease, they are probably not going to get rid of someone's migraine disease. So just be a little bit careful if you ever hear someone say, oh, you're getting headaches, you're probably not drinking enough water, or you're not sleeping enough. It could be the case, but it's a lot more likely that someone has migraine and these things are exacerbating their migraine instead of causing it. Kind of similar to if, someone has hypertension and they're drinking caffeine. I wouldn't say to them, oh, quit drinking caffeine and then come back and we'll think about treating your hypertension. I would say to them, the caffeine is probably not helping your hypertension, and I would recommend to limit it. So it should be looked at in the same light here. There are studies that show that when you do these things, eat well, hydrate properly, don't drink too much caffeine, make sure you're sleeping, exercising. Scheduling is a big thing with that too. The migraine brain does very much like regularity. And then also counseling can be very helpful. So I would say another thing that's very important is doing these things continuously or on some kind of schedule. Like if you skip a meal, or if a patient with migraine skips a meal, that could be something that could very well trigger an attack. It's just probably not the root cause of their migraine disease. Okay, so now we have to kind of bring it all together. So in clinical practice, one big mistake that I often see people make is they will say, okay, you have migraine. Here's a triptan. Go take it when you have an attack, and then come back and we'll see if it worked. I would caution you not to do that. It is very important that people with migraine have what I like to call the migraine medicine cabinet, especially because migraine can be excruciatingly painful. And when people are in a lot of pain, they will go to the ends of the earth to alleviate their pain in whatever way they can. So we really need to do our part to make sure that we are treating migraine disease properly. Otherwise, that's how things like opioid addiction happens. Because when you're in pain, you can become desperate and you can do lots of things that you never thought you would end up doing. So please, if you are seeing and treating a patient for migraine, let's make sure their migraine medicine cabinet is full. So prevention. Do they need prevention? Not everyone needs prevention, but it doesn't take much to qualify for it. And you really have to ask the right questions. So if someone says, I have 3 migraine attacks a month, and then you say, how long do those attacks last? And they tell you 2 days each. Now we have someone who's having 6 days of pain a month. And on top of that, they might have kind of what we like to call migraine hangover after their attack is over with. And so they might not be able to function the 3rd day after the head pain is gone. They still might not be able to think. And so now you have someone that's having 9 days of disability a month. And that doesn't work very well in someone who's a working adult, who needs to go to work, who has a family, who has children they need to take care of. So don't let the initial number fool you. Just because you ask someone, how many attacks do you have a month, and they tell you 2 to 4, that doesn't mean that they are only losing a few hours of their life a month. It means they could be losing days. So really, really talk to them about what their level of disability is and how many actual days they are having pain. Sometimes it's better to ask, on how many days a month are you not in pain or not impacted in a meaningful way by your migraine disease, so that you can't work and you can't take care of your family. And if it's anything at all, more than maybe like 1 or 2 or 3 head pain days a month, so in other words, they're functional on 27, 28 days of the month, I would strongly consider prevention for this person, so that we can try to prevent some of these attacks from happening in the first place. The other thing that they're going to need is acute treatment, because more than likely they are going to have breakthrough migraine attacks. It is not a common occurrence for you to put someone on migraine prevention and they come back and say, that's it, my migraine is gone, I have no more attacks. Could happen, but almost certainly won't. So don't expect that. This patient needs prevention and they need acute treatment. And I would recommend giving them more than one. So another mistake that I feel that some providers make is they will only give a patient one thing to take when they're having an attack. And I think that we need to be a little bit more aggressive than that. I would give them some kind of NSAID, some kind of triptan, and you could even give them some kind of antiemetic. Especially that way, they feel like they have options. They feel like they have choices. And a lot of patients can distinguish whether or not an attack is a milder attack or a really bad attack. So it's better if they have options, and if they feel like they're getting a really bad attack, they can actually combine multiple medications together, and you have to make sure your patient understands that. So if they're having a really bad attack, it's okay to take that NSAID, that triptan, and that antiemetic if they feel like they need it. And then maybe when they're having a milder attack, they only need the triptan and they only need the NSAID. But we just want to make sure that this patient knows that they are going to have something that they can reach for when they are in pain, and that they have different options that they can use, and that it's okay to combine medications when they feel like they need to. All right, last thing, and then we're done. We have to talk about medication overuse headache. I met a girl one time who said, I have migraine. And I said, oh, well, that's interesting. Tell me about that. And she said, well, my mom told me to just take ibuprofen every time I got a migraine attack. So I take ibuprofen every day. And I thought, oh my goodness, she takes ibuprofen every day. And so I had to explain to her that it's not healthy to take ibuprofen every day for a number of reasons. But the broader point to this story is she probably had put herself into medication overuse headache. And when someone is in medication overuse headache, that is a secondary headache. Your body has become addicted to whatever you were using as a treatment. And if you withhold it, you are going to get a withdrawal headache. So when you see someone in medication overuse headache, the first thing you have to do is try to get them out of it. So you can try to figure out what their headache is like at baseline, what type of headache they have, etc., etc. So the point I'm making to you here is whenever you're treating migraine, let's try to keep the patient from going into medication overuse headache in the first place. So caution them to not take their acute treatments every day. If they are taking their acute treatments every day, the first question you should be asking yourself is this patient on prevention? And if they are not, you need to put them on prevention. And if they are, their prevention isn't working. So you need to change it to something else and see if you can get it under better control. Really encourage your patients to not use an acute treatment more than 3 to 4 times a week. You can alternate treatments if that helps, but you still should not be taking something every day. Now, some of our newer medications like Ubrogepant, Nurtec, the really cool thing about them is that they don't seem to cause medication overuse headache. But I'm kind of coming at this from an approach of you're probably not going to be starting with the newer, more expensive medications. You're probably going to be starting with the ones that do cause medication overuse headache. So just be careful. Tell your patients, because if you get into medication overuse headache, the headache is not going to get better. So be really careful about that. All right, well, it's really been a pleasure to get the opportunity to speak to all of you. And if you have any questions or you want to know more about headache treatment, I encourage you to send me an email, and I'd love to talk to you about it. And I wish you all the best of luck in the future.